Good afternoon, everybody. This is the last talk. Okay. My experience of thalidomide in leprosy. Before going to my experience, just some introduction about thalidomide. Thalidomide was synthesized in 1954 at Germany. It was used in Europe as a non-barbiturate sedative drugs or hypnotic drug and anti-emetic drug for morning sickness. But in later in 1950 to 60 eras, more than 10,000 children, they were born with special deformity phocomalia due to adverse effect of thalidomide. And for this, it was withdrawn or banned totally in 1961. But in 1964, thalidomide's resurgence came due to its remarkable activity against ENL. So thalidomide at last gained its FDA approval and reintroduced in the market in 1998 only for one indication, that is ENL. So since that time, around 30 years passed, most of the leprologists, dermatologists now have more experience of using thalidomide over this time. So just little bit regarding thalidomide. Mechanism of action, it has no bactericidal or no bacteriostatic effect of M. leprae. It is basically an anti-inflammatory drug, but it is only effective in the treatment of ENL, not in type 1 leprosy reaction. And its effectiveness is due to anti-inflammatory action, that is due to selective inhibition of the pro-inflammatory cytokine TNF alpha produced by the monocytes. So basically it is an TNF alpha inhibitor. Pharmacokinetics, peak level 2 to 6 hours, bioavailability 67 to 90%. Half-life, mean half-life, it is most 6.5 hours. Metabolism through the hepatic cytochrome P450 system. Excretion mostly renal. Indication in leprosy, only FDA approved indication, that is ENL. After introduction of MDT in 1983, we have achieved a very good result in the treatment of leprosy, including clofazimine as an anti-inflammatory drug. But still then, a significant proportion of patients still develop type 2 leprosy reaction or ENL. I am not going about details about ENL. It is an immune complex mediated complication mostly found in the lepromatous pole of leprosy that occurs mostly within 6 months of initiation of treatment, but can be seen before, during and after treatment. In ENL, particularly in type 2 leprosy reaction, particularly iridocyclitis, orchitis, arthritis, lymphadenitis, nephritis, rather nephritis, that is focal glomerular nephritis, is one of the leading, though it is rare, but it is the leading cause of death in ENL patient. There are some documented complications in ENL. That's why to protect this organ damage, we have to go for a safe treatment. So as ENL is a very chronic condition, any treatment has to be prolonged, definitely. So corticosteroids are the mainstay of treatment because it is the quick anti-inflammatory and immunosuppressant, only to relieve the symptoms. But corticosteroids cannot prevent the recurrence. And their continuous use will lead to many complications like diabetes, hypertension, peptic ulcer, osteoporosis, impaired wound healing, etc., etc. So most chronic and recurrent ENL patients, they are treated with long periods of steroids that commonly lead to steroid dependency. And in India, definitely, you know, it is very easily available over the counter. Patients go and take Isolone. Even if you warn the patient repeatedly, they don't obey. I have seen many patients, almost all patients. Sir, Isolone 5 दिन खाने में तो ठीक हो जाता, आपने क्या दे रहे हो? Ulta, they ask such type of questions, and they take Isolone very easily from the market. So dependency in India is much more. For this, we need an effective and safe treatment for ENL. Absolute contraindication in thalidomide. It is the international guideline. Yes, sensitivity, pregnancy, women of childbearing age, patients with existing peripheral neuropathy. For men, the only absolute indication is that men engaging in sexual intercourse with women of childbearing age. Relative, I am not going details. Now I am starting my study. What is my experience? I am not going details about thalidomide. What is my experience? I describe my experience or our experience of use of thalidomide in OPD basis in the management of PNL. So in SIMS OPD Bilaspur, we have encountered 15 patients with severe ENL who are enlisted. Actually, Dr. Ganguly, when they requested me to prepare this, I got only 2 months or 2.5 months. So I collected only 15 patients outcome. So this is my experience. So data were collected on all ENL patients for demographic details, disease parameters, clinical features, treatment compliance, adverse effects, and treatment outcome, including death. We have excluded women of reproductive age group or women who have not completed their family. Males are advised to use condoms and not to father children during treatment and up to 1 month after the completion of treatment. So this is the methodology we followed in OPD basis. So patients were prescribed 4-week course of drug during each visit, means each month. Routine lab investigation like CBC, LFT, RFT, serum electrolytes were done. Except steroids, other drugs were stopped. Other drugs means mostly chloroquine or increased dose of clofazimine already advised by some other people or periphery, we have stopped it. Because steroids, so definitely mostly dependent patients are coming, so you cannot abruptly stop the steroid. Gradually you have to taper. I am coming. What is the thalidomide protocol we observed? 300 milligram once daily for 1 month, then 200 milligram once daily for 1 month, then 100 milligram once daily for 1 month. In some patients, particularly when the patients complain of sedation, daytime sedation, for them we advise to take single dose at night time, or those patients who are not complaining any sedation, so we can give 100 milligram TDS for 1 month, followed by BD for 1 month, then followed by OD for 1 month. After that, the patients are maintained on 100 milligram alternate day for 2 to 3 months or until complete remission, and then gradually tapered and gradually stopped. During this regimen or protocol, because most of the patients are steroid dependent, and mostly the steroid dependent patients, for any relapse, that means some patients they develop or they flare up ANL after 1 month or 2 months. After tapering down the thalidomide dose on the 3rd month onwards, particularly, some patients they had some flare up. So for them, when there is any relapse or deterioration, we just raise the dose immediately to 300 milligram. We didn't increase the dose of corticosteroid. Rather, we increase the dose of thalidomide. And then slowly reduce 100 milligram every month, then maintaining. First I am coming to this is not result, this is actually graph. So we have taken 15 patients, males were 14, female 1, and that female 45 or 48 years old and completed her family. Age group 20 to 50 years, married 3, unmarried 12. Those married 3, they have completed their family. Bachelor index 4 plus, more than 4 plus 6%, equal to or less than 4, it is 9%. And according to Ridley-Joplin classification, lepromatous polls mostly BL or LL 12%, 6.6, and mid-borderline we have taken 3%. Out of these 15%, 14% they started thalidomide because of steroid dependency and recurrent ENL. Only 1% on acute ENL. This man, only 1% who is diabetic, having comorbid diabetic, and he was on oral hypoglycemic drugs. And that time blood sugar was 346 or 350, like that. This patient directly came to OPD with these features. So this is the only patient, one patient on acute ANL. This patient, one patient acute ANL with comorbid diabetes mellitus. Okay. We have started thalidomide before starting MDT. And all other 14 patients, they were steroid-dependent patients. Okay? On average, the duration of PNL ranged from 7 months to 9 months. The number of recurrent attacks ranged from 2 to 12 episodes. Out of these 14 patients, 9 patients completed MDT and 5 patients were on MDT. 4 patients already have told with comorbids like diabetes and hypertension. 1 patient, this one. Okay. So now my methodology. The patients were encouraged to take the drug in the night to minimize sedation. Those who complained daytime sedation. The patients were followed up every month, were monitored for any adverse events and disease progression. Response to thalidomide was assessed by complete patient recovery and measuring further ANL episodes. Early institution of thalidomide within 1 month of ANL onset in one of these patients, particularly this patient, we got good result, faster remission and prevented. Actually, already it is 1.5 months past and the patient has not flared up any further ANL. Okay? But the remaining patients, those who were steroid dependent, they required thalidomide for a longer period, more than 6 months. So patients initiating thalidomide with BI less than or equal to 4 had 37% increase recovery incidence compared to BI greater than 4. The recovery was 3 times greater among those who have completed MDT as compared to on MDT. In my observation, in these 14 patients, no deaths have been observed in my study. This is just an photograph of one patient who was steroid dependent, young patient, unmarried man. 6+ Bachelor index was there. But after 3 months, this is the scenario, and there is well control, and steroid has been totally stopped. Adverse events. What I got in those 14 patients? Patients were on thalidomide treatment for a mean of 9 months. The commonest effect what I got in my experience was pedal edema. In 74%, I got pedal edema, followed by drowsiness in 21%, and last constipation in 5.9 or 6%. So side effects of thalidomide treatment were observed mostly in the first month, or first 1 month or first 2 months of initiation thalidomide, and gradually it decreases in the subsequent months. I did not record peripheral neuropathy as such, but associated symptoms like paresthesia, numbness, burning sensation, weakness and cramps we got. Here I will elaborate later slide. In later slide I will elaborate something. However, it can be reduced by decreasing dose. All the complaint of patients recovered completely while on thalidomide therapy in gradual months. First, I am coming to my first adverse effect, that is pedal edema. That I got maximum. In my experience, what we observed in these 14 patients, pedal edema was the commonest adverse effect noted in 74% patients, which is comparable with Walker et al. Study, where pedal edema is the commonest side effect recognized. Hence, one can expect its increased incidence during thalidomide treatment. What is the mechanism? Why there is edema? The edema, it is mostly remains unknown, but may be due to stasis of blood in the extremities and occurs at high doses. I told that after 1 month or 2 months, gradually decreases. So, it is not a warning sign to withdraw the medicine or to decrease the dose. So, what can be done as a physician or clinician? In my experience, I have given Diter 5 or Diter 10 milligram. Diter is torsemide. So torsemide I have given to some patients, around 8 to 9 patients, for 1 week. Just you give them after lunch, daytime. Don't give it at night time because of frequent urination. So you can give and tell the patient leg rise for 1 week with Diter 5 milligram or 10 milligram. And it is very good result. It gives very good result, and there is no need to withdraw or decrease the dose of thalidomide. This is my experience that this you can expect during the first month or second month of thalidomide. If there occurs, just you tell the patient leg rise and you can give low dose of torsemide, 5 milligram or 10 milligram. That is my experience. In addition, we observed that if the patients were on high dose of steroids for a long period, they took more time to improve. Yes. Why? Because the corticosteroids, they suppress the activity of the adrenal cortex, and a certain time period is necessary to regain its activity, to resume its activities. So after 1 month or 2 months or 3 months, then gradually thalidomide starts to work. In our study, none of the patients had DVT, but it is very important for all the clinicians. The increased risk of DVT may occur due to combination of corticosteroid with thalidomide. So that you should keep in mind, DVT. Though I didn't experience case of DVT in thalidomide, but it can happen to anyone. So you can have this knowledge of DVT that may occur in corticosteroid with thalidomide. Second complication, mostly drowsiness. This one. Somnolence, fatigue, drowsiness. These are the other common side effects. In my experience, we have seen many patients. They told, कि sir, I am feeling drowsy, काम करने का इच्छा नहीं होता है, कुछ नहीं होता. Yes, that may be mental, but it may be related to thalidomide or it may be related to corticosteroid also. Because they have taken corticosteroid for a long time. So it is a non-specific, but you can observe in many patients. So you just tell the patients not to do hazardous tasks and don't use alcohol. Regarding constipation, it was my third observation that I got in only 6% people. And it is also a very simple thing, and it can easily be managed by the physician with change of diet, otherwise good fiber diet, sufficient water drinking, mild exercise, and you can use low dose of stool softener like lactulose you can give. If there is severe constipation, I didn't get any experience of severe constipation, but if you get, then you can go for enema, or you can withhold for few days of thalidomide. Now coming peripheral neuropathy, what mostly the textbook or many journals they have reported. In my experience of these 14% patients, I didn't get any sure case of peripheral neuropathy, but I got numbness, burning sensation, weakness and cramps. Neuropathy, peripheral neuropathy usually presents with sensory and motor symptoms, mild proximal muscle weakness with symmetric painful paresthesia of hands and feet, frequently associated with lower limb numbness, tingling, sensory loss. Here I will tell one thing. You have to remember two things, clinical importance. One is paresthesia. If there is painful hand and foot after taking thalidomide, then it is a case of peripheral neuropathy, clinically. And if the patient will tell कि सर मेरा थोता तो यहाँ तक था, last 1 month से यहाँ तक बढ़ गया, it is not a type 1 lepra reaction. So increased numbness or anesthetic area and painful hand and feet, it is a sure short clinical sign of peripheral neuropathy. So these two clinical features you should ask the patient every time. That's why, though we are not able to do at every time, in my opinion, you must do a baseline nerve function test in all patients before starting thalidomide. Definitely, you must do, because we don't have neurology department, so sometimes we have to send the patient to private setup, and sending a leprosy patient to private setup means it is a crime for a government doctor. So there are some difficulties. Definitely, sir, in AIIMS or Pandit Jawaharlal Medical College, they can do easily because they have own neurology department, so nerve function test can be done. So in my experience, what I have found in 2 cases, sir, हाथ पैर में दर्द हो रहा है and some numbness has increased. So I gradually decreased the, abruptly decreased the dose up to 100 milligram and started some calcium, vitamin D3 and cyanocobalamin. After 1 month or 2 months, then I gradually increased the dose. I am not sure कि उसको peripheral neuropathy था या नहीं था, because I could not do the nerve function test. I am telling you, because you cannot send the leprosy patient to a private sector. Then many explanation will, so cause notice will come to you. Anyhow, so in my experience, in my opinion, every doctor should have a baseline nerve function test before giving thalidomide. So if there will be 30% decrease of nerve function, then you reduce the dose. If the nerve function decrease will more than 40%, you stop thalidomide. It is the national guideline, international guideline. Okay? So electrophysical testing at baseline is must, and every 6 months thereafter to detect any asymptomatic neuropathy. If facility is there, then every 6 monthly you can do. If there is, then dose reduction or cessation therapy. So I have told, if 30% decrease, decrease the dose, more than 40% decrease, stop thalidomide. So monitoring guidelines, there is steps. What is steps? System for thalidomide education and prescribing safety. Actually, in America, particularly US, physicians and pharmacists registered with steps, they are only permitted to give thalidomide. And this is the international guideline. What is the international guideline? Before giving thalidomide, definitely pregnancy test must be done in all childbearing women. But I have not given, so I don't have any experience, or I don't give also. So we can go weekly test for 4 weeks, then monthly. Routine immunization, definitely CBC, platelet count, serum, electrolyte, RFT, LFT, monthly and 3 months. Neurological examination, clinical neurology examination, monthly for 3 months, thereafter 1 to 6 months as indicated. So nerve conduction studies must be done every month for first 6 months, then every 6 monthly onwards. So already this I have told you. If it decrease by 30%, decrease the dose. If by 40% decrease, stop thalidomide. So in my experience, what my observation, I gained that steroid dependence was almost mostly 90% patient. So dosage and duration of thalidomide in ENL has been areas of uncertainty. Yes, I may be forced at some times to increase the dose from 100 to 300. In case of deteriorations, already told, high dose can be initiated. The longer duration of treatment is mostly due to steroid dependency. However, NL recurrence was observed in 16% patients, probably due to late initiation of thalidomide. Sometimes we do late. Actually, since last 6 months, our hospital is having free supply of thalidomide, but before that, patient has to buy. So sometimes it was creating some problem. Or otherwise, some poor patients having BPL card, they can get free medicine, but you have to sign from the medical superintendent, they will send to chemist. So it takes another 1 month. So there may be some delay in thalidomide from local purchase. Okay. So thorough counseling to the patient, avoid pregnancy. Okay. Clinician must be aware of the occurrence of pedal edema, particularly at high doses, and this does not warrant any discontinuation. So in my last sentence, we advise not only to hit hard, but also hit early with thalidomide for treatment of anal, because it gives quick, effective response, and organ damage like eye and kidney. So these are the references, and thank you. I have a very short experience.